Picture this, a woman named Eleanor. She's 74 years old, retired, still drives herself to church every Sunday, still does her own crossword puzzles in ink. She goes into the hospital on a Wednesday afternoon after feeling dizzy and short of breath, nothing that feels like a crisis. She walks in on her own 2 feet. The staff at the front desk are polite. They put a wristband on her, hand her a stack of papers, and she signs them the way any reasonable person would, because that is simply what you do when you are standing in a hospital and someone hands you a clipboard. A doctor sees her, a bed is found. She is told she needs to stay for a few days so they can monitor her heart. She feels reassured. She is exactly where she is supposed to be, being cared for by people who know what they are doing. 4 days later, Eleanor goes home. Her dizziness is under control. She is grateful and relieved. And then, roughly a month after she is discharged, the envelopes begin to arrive. One is from a cardiologist she does not remember ever speaking to, a specialist who reviewed her case from outside her insurance network. One is from the hospital itself, for the whole length of her stay, and it is far larger than she ever anticipated because, as it turns out, Eleanor was never formally admitted as an inpatient at all. She was placed under something called observation status. And because of that single classification, the rehabilitation stay her own doctor recommended afterward is not covered the way she assumed it would be. Eleanor did nothing careless. She asked polite questions. She followed every instruction she was given. But nobody sat her down and explained the 5 things that could have protected her, and by the time she truly understood what had happened, the window to challenge any of it had already begun to close. My name is Dr. Mason Hayes. I have spent 21 years specializing in senior health, sitting with families in exactly these moments, watching good people get caught in a system that was never built to be transparent with them, and what I am going to walk you through today are those 5 things. 5 hospital and Medicare traps that catch seniors every single year, not because those seniors are foolish or inattentive, but because nobody explains the rules clearly enough before those rules start to matter. Stay with me all the way through all 5, because they build on each other. Trap number 4 is the one that almost nobody thinks to ask about, and yet it quietly shapes so much of what happens. And trap number 5, the one about how a hospital classifies you the moment you walk in, is the single most financially consequential thing I cover anywhere. It only makes complete sense once you understand everything that comes before it. If this channel is new to you, take a moment and subscribe now. This is what we do here. Calm, clear, honest guidance for adults who want to understand the system before the system starts making decisions on their behalf. Let's get into it. Before I hand you the 5 traps, I need to give you one framework first, because without it the individual traps will not fully connect in your mind. I call it the assumption gap, and it is the reason Eleanor's story repeats itself thousands of times every single day across this country. Here is what changes about your relationship with the healthcare system after the age of 65. 3 things specifically. First, the rules become more complex, not less. Most people assume that once you are on Medicare, coverage becomes simple and predictable. In reality, Medicare's rules around hospital admissions, observation status, and post-acute care are among the most complicated rules in the entire American healthcare system. What you do not know genuinely, measurably costs you money. Second, the paperwork you sign carries far more weight than you realize in the moment. Admission documents at most hospitals contain financial clauses that most patients never read and that most staff never pause to explain. Signing without understanding can legally transfer financial responsibility onto you for costs that might otherwise have been disputed or reduced. Third, and this is the one that ties everything together, hospitals and insurers operate inside a system that is designed around their interests, not around yours. I want to be careful here, because that is not cynicism and it is not an accusation of bad people doing bad things. It is simply how the incentives are structured. The assumption gap is the space between what most seniors believe their coverage includes and what it actually includes under very specific conditions. Every trap on today's list lives inside that gap. Keep that framework in your mind as we move through each one. Now, I want to ask you something. Think back to the last time you, or someone you love, dealt with a hospital stay, or even just a visit to the emergency room. Do you remember how quickly the paperwork moved? How fast someone slid a clipboard in front of you? How little time there really was to read anything carefully, let alone stop and ask thoughtful questions? Most of the people I speak with describe the very same experience. You are focused entirely on the health situation in front of you. You trust the institution, and rightly so in many ways. You sign what they hand you, and you assume that is simply the correct thing to do. Nobody ever pulls you gently aside and says, Here are the 5 things you really need to ask before you agree to anything at all. If any of that sounds familiar to you, then this video was made specifically for you. Here is what I need you to understand before we go any further. The financial and coverage problems that so often follow hospital stays for seniors are not inevitable. They are, to a remarkable degree, preventable if you know the right questions to ask at the right moments. The rules already exist. The protections already exist. Federal law gives you rights inside that hospital that most people never once exercise, simply because nobody ever told them those rights were theirs. That is what today is truly about. Not fear, not doom. Practical knowledge that puts you back in the driver's seat of your own care. Let me explain something about how hospitals and insurers actually process patients, because once you see this clearly, all 5 traps will make immediate, intuitive sense. When you arrive at a hospital, 2 entirely separate systems activate at the very same time. The clinical system, which is the doctors, the nurses, the treatment itself, is focused squarely on your health. The administrative system, which is the billing, the coding, the classification, is focused on how your stay gets categorized for payment purposes. And here is the crucial thing. These 2 systems do not always communicate well with one another. The category your stay gets assigned to, often within the very first few hours of your arrival, can quietly determine tens of thousands of dollars in coverage outcomes. Think of it like checking into a hotel. Whether the front desk logs you as a standard overnight guest or as a conference attendee changes which services are quietly included in your rate. You are sleeping in the same room. You are eating the same breakfast. But the billing behind the scenes is completely different, and nobody at that front desk is required to explain the difference to you unless you specifically ask. A report from the Office of the Inspector General found that Medicare patients placed under observation status rather than formally admitted faced significantly higher out-of-pocket costs per hospital stay compared to those admitted as inpatients. That is not a billing error slipping through the cracks. That is the system working precisely as it was designed to work. Now, in my 21 years, I have found that there are 5 specific traps inside that system that seniors encounter most frequently and, thankfully, most preventably. I have ordered them from the most common to the most critical, so you know exactly where to focus your attention first. The final one affects more people than any other item on this entire list, and its financial consequences can be genuinely devastating. But you need to understand the first 4 to fully appreciate why. Let's begin. Trap 1. Out-of-network surprise bills. When Margaret was 68, she had solid Medicare coverage and a supplemental plan she had faithfully carried for years. She went in for a planned cardiac procedure at a hospital that was firmly in her network. She even asked the right questions ahead of time, confirming that her surgeon was in network. 3 weeks later, she received a bill for over $4,000 from an anesthesiologist she had never met and had certainly never chosen, someone who had assisted during the procedure, but who was not part of her network. Most people naturally assume that if the hospital and the primary physician are in network, then everyone involved in their care will be too. That assumption is simply wrong. Hospitals routinely rely on contracted specialists, anesthesiologists, radiologists, pathologists, surgical assistants, who each maintain their own separate network agreements. These providers can bill independently, and the in-network status of the hospital does not automatically extend to cover them. The No Surprises Act, which took effect in January of 2022, offers federal protection against many of these bills. Under this law, for most planned procedures, out-of-network providers cannot bill you more than your in-network cost-sharing rate without your explicit written consent given in advance. The key word there is explicit. If you sign a general financial consent form without realizing it contains a clause waiving your No Surprises Act protections, that waiver can hold up. So here is the practical guidance. Before any planned procedure, ask the hospital in writing for a list of every single provider who will participate in your care. Ask specifically which of those providers are in your network. If any are out of network, ask whether you can request an in-network alternative instead. And if you are asked to sign any document consenting to out-of-network billing, read that clause carefully before your pen ever touches the page. The common mistake is assuming that a signed general consent form carries no specific financial implications. It very often does. Any form containing the phrase financial responsibility or non-participating provider deserves a slow and careful read before your signature goes on it. And if you receive a surprise bill after a procedure and you believe the No Surprises Act applies to your situation, you have the right to dispute it. The federal dispute process is available through CMS, the Centers for Medicare and Medicaid Services, and your insurer is required to provide you with information about how to begin it. Within the first 30 days after receiving a bill you believe is incorrect, contact your insurer and request an itemized statement. Document every single call, the date, the name of the person you spoke with, what they told you. The earlier you raise the dispute, the more options remain open to you. Now, Trap 2 catches people in a completely different moment, not when the bill arrives, but when the hospital tells you it is time to go home. Trap 2, premature hospital discharge. Frank was 74. He had been admitted after a fall that resulted in a hairline fracture. After 3 days, a hospital administrator, not his physician, informed him that his insurance had approved his stay only through the following morning and that he should plan to be discharged. Frank felt unsteady on his feet. His pain was not yet well controlled, but he assumed that if the insurance said it was time to go, then it must be medically appropriate. He was discharged, and he fell again at home just 2 days later. Here is what Frank did not know. Medicare beneficiaries have the legal right to appeal a hospital discharge decision before leaving, on the very same day if necessary. This is not a complaint form. It is a formal federal right. It is called a Quality Improvement Organization appeal, or a QIO appeal. Every Medicare patient must be given a written notice called the Important Message from Medicare, which explains this exact right before discharge. If you were never given that notice, the hospital is out of compliance. Research from the Commonwealth Fund found that roughly 1 in 5 Medicare patients is readmitted to the hospital within 30 days of discharge, and premature discharge is one of the most frequently cited contributing factors. Readmission carries its own set of costs, risks, and coverage complications. So here is the practical guidance. If you or a family member feel that a discharge is happening before it is medically safe, request a QIO appeal immediately. You do not need a lawyer. You do not even need your doctor to agree with you. You simply call the QIO. The phone number must be printed on that important message from Medicare document, and you request a review. Medicare will pay for your continued stay while the appeal is being reviewed. The hospital cannot discharge you during that review period. The common mistake is waiting until you are already home to raise the concern. Once you leave, the process changes significantly and your options narrow. The time to act is before discharge, never after. Quick pause here. Have you or someone in your family ever felt that a hospital discharge happened far too fast? Drop a yes or a no down in the comments. In my experience, this is much more common than most people realize. And the people who successfully appeal are almost always the ones who already knew this right existed before they ever needed it. Trap 3. Medication substitutions during your hospital stay. Ruth was 71. She took 4 medications daily, ones that her own doctor had carefully selected and adjusted over the course of several years. When she was admitted for a knee replacement, the hospital quietly substituted 2 of those medications with alternatives from its own formulary, which is simply the hospital's approved internal list of drugs. Nobody asked her, nobody explained why. She assumed the hospital knew best. After discharge, she experienced side effects she had never had before, and she spent 2 long months working with her doctor to restabilize her regimen. Here is what most people do not know. Hospitals maintain their own formularies, their own approved drug lists, and when your regular medication is not on that list, they will often substitute an alternative without any specific patient consent beyond the general admission paperwork. This is standard practice. It is also perfectly legal. But it creates real problems when the substitute behaves differently in your body, interacts with the other medications you take, or creates a transition challenge at discharge when you attempt to return to your original regimen. A report published in the American Journal of Health System Pharmacy found that medication discrepancies at hospital admission affected a significant portion of older adults, particularly those taking 5 or more medications, and that these discrepancies were a leading cause of adverse drug events both during and after hospitalization. So here is the practical guidance. Before any planned hospital stay, write out a complete medication list. Every drug, every dose, every frequency, including any over-the-counter medications and supplements. Bring that list with you when you are admitted, hand it to your care team, and ask them directly, will any of these medications be substituted during my stay? And if so, can you explain the reasoning and how we will transition back at discharge? You have the right to ask. You have the right to involve your own physician in that conversation. The common mistake is assuming the hospital's pharmacy team is automatically coordinating with your regular doctor. In many cases they are not. That handoff is your responsibility to initiate. This is not medical advice. Your specific medications and your medical history require a conversation with your own physician. but the simple habit of bringing a complete written medication list to every single hospital encounter is one of the most protective things you can possibly do for yourself. Now, we are going to shift gears. What I am about to cover next is the part of the hospital experience that most people never think about until it has already happened to them. These last two traps are where the real financial exposure truly lives. Trap 4. Financial responsibility forms buried inside the admission paperwork. Most people know they will be asked to sign paperwork when they are admitted to a hospital. What most people do not know is that those documents often contain financial clauses that go significantly beyond a standard consent to treatment. Martin was 69. He was admitted through the emergency department after a cardiac event. Understandably, he was in no condition to read anything carefully. He signed everything quickly, just to get to the care he needed. Among those documents was a clause agreeing to be financially responsible for any charges not covered by his insurance, including charges arising from coverage disputes. 18 months later, when his insurer denied a portion of his claim, the hospital used that very signed document to pursue him directly for the balance. A 2021 analysis by the Kaiser Family Foundation found that more than half of American adults reported difficulty affording health care costs, and that surprise billing and unexpected out-of-pocket charges were among the most commonly cited sources of financial hardship. For seniors living on a fixed income, a single unexpected hospital bill can represent months of income vanishing all at once. So here is what you can do. If you have any capacity at all to review admission paperwork, or if a family member or an advocate is there with you, look specifically for language about financial responsibility, assignment of benefits, and non-covered charges. You are allowed to ask questions before you sign. You are allowed to cross out or annotate specific clauses. Write the words "I do not agree to this clause" next to any language you are uncomfortable with, and initial it. This does not guarantee the hospital will honor your annotation, but it creates a documented record of your objection that can matter enormously in a later billing dispute. If you are admitted through an emergency and simply cannot review documents in advance, you can request a copy of everything you signed once you are stable, and you have the right to dispute charges that arose from clauses you were never in a position to review. The common mistake is assuming that because you signed something quickly, under duress, you have no recourse. That assumption is not always correct. Many billing disputes are successfully resolved after the fact, but they require documentation and quiet persistence. Now, here it is, the trap that changes the entire conversation and the one that connects directly back to Eleanor's story from the very beginning of this video. Trap 5. Observation status versus inpatient admission. This is the most misunderstood and the most financially consequential classification in all of Medicare, and I want to explain it clearly, because the details here matter enormously. When you arrive at a hospital and a physician orders you to stay, you and your family will almost certainly assume that you have been admitted as an inpatient. In a surprising number of cases, you have not. You may instead have been placed under observation status, a classification that means, under Medicare's rules, you are technically an outpatient receiving extended monitoring, even if you are occupying a hospital bed for multiple days and nights. The practical difference is staggering. Under Medicare Part A, inpatient admissions cover your hospital stay and, critically, make you eligible for post-acute rehabilitation coverage at a skilled nursing facility, provided you meet the 3-day inpatient stay requirement. Under observation status, none of that applies. Your hospital stay may be billed under Medicare Part B instead of Part A, often at a higher out-of-pocket cost, and you are not eligible for covered skilled nursing facility care, regardless of how many days you actually spent lying in that hospital bed. A report from the U.S. Government Accountability Office found that the number of Medicare beneficiaries placed under observation status for more than 48 hours rose dramatically over recent years, and that many of these patients had no idea of their classification until the bill arrived in the mail. The financial consequences for those who needed post-acute rehabilitation care were severe, with some patients facing skilled nursing facility costs of $500 or more per day that Medicare would simply not cover. The Notice of Observation Treatment and Implication for Care Eligibility Act, known simply as the Notices Act, requires hospitals to notify Medicare beneficiaries in writing within 36 hours if they are under observation status rather than admitted as inpatients. That notification is called the Medicare Outpatient Observation Notice. You are entitled to receive it. If you do not receive it, ask. So here is the practical guidance. Within the first 24 hours of any hospital stay, ask your nurse or your care coordinator directly, am I formally admitted as an inpatient or am I under observation status? Write down the answer and write down who gave it to you. If you are under observation status and you believe your condition genuinely warrants inpatient admission, you or your physician can request a status review. Your doctor's clinical judgment about the appropriate level of care carries significant weight in that review. Instead of waiting to find out at discharge, ask on arrival. Ask again after 24 hours if the answer was observation status. If you are told that inpatient admission requires authorization, ask who is responsible for pursuing that authorization and what the timeline looks like. The common mistake, and it is the single most costly mistake on this entire list, is assuming that if the hospital put you in a bed and kept you for 3 days, then Medicare will automatically count those 3 days towards skilled nursing facility eligibility. That one assumption has cost seniors and their families staggering sums in uncovered rehabilitation costs. The question costs you absolutely nothing to ask. The answer can change everything. Before I give you your 30-day action step, I want to leave you with something you can use at your very next hospital encounter, or hand to a family member who might face one. I call it the Hospital Admission Safety Protocol. 5 questions. Write them down. Save them in your phone. Give this list to whoever is most likely to be sitting beside you in a hospital setting. Question 1. Am I being formally admitted as an inpatient, or am I under observation status? Question 2. Can you give me a list of every provider who will be involved in my care today, and which of those providers are in my insurance network? Question 3. Will any of my current medications be changed or substituted during this stay, and can my own physician be consulted before any changes are made? Question 4. What are my rights if I believe I am being discharged before I am medically ready to leave? Question 5. Is there anything in the paperwork I am being asked to sign that makes me financially responsible for charges my insurance may not cover? Any good hospital patient advocate, social worker, or physician will genuinely welcome these questions, and if the response you receive somehow makes you feel that asking was inappropriate, well, that tells you something important too. Here is your 30-day action step, and I want to make this specific because vague intentions never translate into real protection. This week, not in 30 days, this week, create what I call a hospital readiness file. It takes about 20 minutes. Write down every medication you take, the dose, and how often you take it. Add your primary care physician's name and their direct phone number. Add the name and phone number of one family member or trusted friend who can advocate for you if you are ever unable to advocate for yourself. Write down your insurance information, including your Medicare number and any supplemental policy details, and write down those 5 questions from today. Put that document somewhere you can grab it quickly, and tell the person you listed as your advocate exactly where it is. That file is your protection, not because anything bad is destined to happen, but because the people who navigate hospital encounters most successfully are almost always the ones who prepared before they ever needed to. Check your file in 30 days. Update anything that has changed. I want to close with something I think about often in this work. There is a real difference between a healthcare system designed to treat illness and a healthcare system designed to protect the person. After the age of 65, navigating the space between those two things requires far more knowledge than most people are ever handed. The traps we talked through today are not the result of malice. They are the result of a complex system that was simply never designed with your financial protection as its primary concern. The very best patient advocates I have ever encountered, and I have worked alongside a great many of them, are almost never the ones who are loudest or most difficult. They are the ones who are most prepared. They ask calm, specific questions. They write things down. They know their rights before the moment they need them. And that is exactly what you now have. You know what observation status is. You know what the No Surprises Act protects you from. You know you have the right to appeal a discharge, you know to read the paperwork before you sign it, and you know to bring your medication list every single time, without fail. In 21 years, I have watched that quiet kind of preparation make a real, measurable difference in the lives of the people I serve. You are not a passive participant in your own health care. You are a participant with rights, and today, at last, you know exactly what they are. If this gave you something genuinely useful, subscribe. That is what this channel is built for. Calm, real, practical guidance for adults who want to understand the system before the system starts making decisions for them. I am Dr. Mason Hayes, and I will see you in the next one. Take care of yourself, and take care of the people you love.